Okay, welcome everyone to GOMI, Global Organization for Wilderness Medicine Education Lecture Series. This week we have military medicine and we're very excited to have you all here today. My name's Claire. I am the Vice Coordinator for GOMI and based out of U Miami. And I have Leo with me, who is our undergraduate delegate at U Chicago. So if you haven't already, please go follow us on Twitter and Instagram. We post all about our series and other opportunities in wilderness medicine, so it's a great way to kind of keep on top of what we're doing. So our mission here is to create an educational platform where interested students and healthcare professionals can explore and interact with wilderness and emergency medicine, and to showcase diverse spheres in which physician and healthcare professionals can make an impact and inspire others to think abstractly about the ways in which we can utilize our careers in healthcare and medicine, and to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. So today we have military medicine, and we have a list of our previous topics, and then we want to get excited for the coming months where we have avalanche medicine, extreme medicine, space medicine, aerospace medicine, and special ops coming up. So put those on your calendar. Today we have Dr. Saguil with us today. He served as Associate Dean for Recruitment and Admissions at the Uniformed Service University of Health Sciences at F. Edward Hebert School of Medicine, America's Medical School in Bethesda, Maryland. He's an Associate Professor of Family Medicine and is on the faculty of the Fort Belvoir Community Hospital Family Medicine Residency. He's the Vice Chair of the AAMC's MCAT Validity Committee, a contributing editor to American Family Physician, Chair of the AAFP's Commission on Continuing Professional Development. He received his BA in chemistry at Duke University and his MD at University of Florida College of Medicine. After completing his residency at DeWitt Army Community Hospital in Fort Belvoir, Virginia, he's been stationed in Grafenwohr, Germany, Fort Lewis, Washington, Fort Gordon, Georgia. He's deployed to Afghanistan and served as the Chief of Primary Care for the NATO Role 3 Multinational Medical Unit in Kandahar, Afghanistan. His actions in theater were recognized with the Bronze Star and the Canadian Chief of Defense Staff Commendation. So we're very excited to have him here today for this very special interactive lecture that we hope you all enjoy. So I'm going to turn it over to Dr. Saguil now.
To unmute myself, so that's the first step. Then I'm going to share my screen with all of you. And here we go. And there we go. So, hey, thank you so much for letting me talk to you. My name is Aaron Saguil. I'm a family physician with the Army, coming up on 22 years of service. So I'm getting old enough now that I'm pretty sure that all of you are young enough to be my sons and daughters. So thank you so much for being willing to stick around till like 5 o'clock in the evening to listen to someone who could be your dad. So with that, let's talk about military medicine, and promise to make this hopefully entertaining for you, because it's a story talk. You are smart, intelligent people. Some of you have been working all day in the clinic or in the wards, and the last thing that you want is an hour-long PowerPoint. So I took my 70 slides and shortened it down to 50, just joking. There's only about 25 slides here. I have about 25 minutes worth of prepared material. As you can see, I talk very, very fast. So it's actually probably closer to like 20 minutes worth of material. So my hope is that you'll ask lots and lots of questions, you'll participate with the stories, and then I can give you a sense of what military medicine is, so that you can consider whether or not it's something that you want to do, or if you just want to appreciate it from afar, both of which are completely reasonable approaches. So the question is, when is it most appropriate to ask questions? And the answer is really any time. Feel free to drop them in the chat. I won't be monitoring the chat because I tend to have ADHD, so I'll be kind of staring at that as opposed to interacting with you. So if one of you wouldn't mind monitoring the chat, if there's a great question that comes up there, feel free to interrupt so we can, it's not really an interruption, just talk and let us know what that question is. Or if you feel brave enough to unmute yourself, feel free to unmute at any time. I'll stop, we'll answer your question, we'll go on from there. It's really intended to be interactive and hopefully a lot of fun. And so I have 3 stories that I want to share with you tonight. The first one is for those of you who met at the NCEMS Foundation conferences. This will be one with which you're familiar. It talks about what it's like to be on a combat deployment. The second story will talk about what it's like to be on a humanitarian mission with the military or with a civilian partner. And then the third story will be what it's like to train for these types of missions. So those are the 3 stories, and this is the first one. And again, interactive, so feel free to ask questions at any point. So just to be completely honest, for complete disclosure, my last time on a combat deployment was back in 2008. So it's been over 13 years ago at this point. But when I was over there in 2007, 2008, I was in Afghanistan. And geopolitically, you can see here on the map that Afghanistan's in a region that has a lot of neighbors in which we're interested. Pakistan to the south and also to the southeast. You have Iran over to the west. You have the Central Asian republics to the north. And you have a small portion of Afghanistan that actually borders on China. Around the map, you see the flags of the nations that were with us as our coalition partners while we were in Afghanistan. And so when I was over there, I think my mouse will show on the screen, but Kandahar is here in the extreme southeast corner of the country, and that's where I was stationed when I was over there. While over there was with a hospital unit, and so this is what a group of Americans that deployed to Afghanistan look like. Within that mix there, without pointing them out by individuals, there's an assortment of medics, ambulance drivers. We have some licensed practical nurses, RNs, as well as physicians, PAs, and nurse practitioners, and some laboratory specialists. Also, people that help us with the aeromedical staging evacuations for people that need to be evacuated to other portions of the theater or possibly back to Germany or the United States. What you see here is a group of multinational specialists with which we were deployed at our hospital in Kandahar. We worked with each other in the same facility. Without pointing them out individually, these are two surgical teams. So you have a group of orthopedists, general surgeons, as well as a critical care intensivist and a couple anesthesia providers, and also an oral maxillofacial specialist. The uniforms there, you're seeing people who are Canadian, Danish, as well as British in that picture. So the question you might have is, what is it that a military physician does when they're on a combat deployment? Well, if you're like me as a family physician, you basically are doing your job just in a very different setting. So as a family physician, I take care of acute injuries. So I did plenty of that while I was over there. Took care of people with chronic medical conditions, trying to optimize their health, took care of that while I was there. And of course, there's the urgent care things like someone has a urinary tract infection, someone develops a gastroenteritis, someone has a heart attack, which happened because we had some people over in Afghanistan that weren't as fit and trim as you might imagine on a combat deployment. So we had to take care of them as well. Interesting thing for the family physician, we're kind of trained to do multiple different things. It's always interesting when your first patient of the day has wings. I was usually in the morning, I would review the radiologic studies from the day before just to make sure there wasn't anything that we missed. And it's really interesting. You're looking like, okay, foot, no fracture, heel, no fracture, arm, no fracture, wings. What? Wings? Yeah. So we also provided some veterinary care while we're over there as well. So those are some of the more mundane things we did. We also did vaccination programs, try to push them out to communities that didn't have access to cold chain storage, so we could actually get those kids vaccinated against preventable illnesses that would potentially lead to death, and also preventive medicine capacity building. But we also did some fairly exciting things also because with two surgical teams, as you can imagine, sometimes in the middle of combat operations, we would receive more casualties than the surgical teams could work on at any given time. And so as a primary care provider, we're taught how to follow ATLS protocols, advanced trauma life support, as well as advanced cardiac life support protocols. And so while the surgeons were in the OR, we would take care of the patients until they were ready for them. So sometimes it got pretty exciting. So this is a story for those of you who have seen me at a conference before have heard, and so we won't take too long to go over it, but it is an opportunity for you to interact. And I know that there's some of you that haven't had the opportunity to work through this before, so I want to give you that chance also. Let me lay out the scenario for you. At 4 o'clock in the morning in February of 2007, I was the only physician at the hospital watching the patients overnight. All the rest of the teams were back in our dorms essentially, and they were getting some rest before the next day's cycle began. So into the middle of that night, we got word that a Chinook helicopter had crashed in a nearby province. And Chinook helicopters are the really large ones. They have two rotary rotors on them, and so they carry a lot of people. Well, when that helicopter went down from a mechanical failure, they had 11 dead that were on the scene, one more that died en route to us. And then we received 11 patients who were alive when they reached us. And it was our responsibility to triage and to get them the care that they needed so they could make it back to the next higher level of care and eventually to the definitive level of care. And so with that, just to put you in my shoes, I was the triage officer because I was the ranking medical officer on the scene at the time. We were waiting for the surgeon to come in. We were waiting for the chief nurse to come in. And so we had to make these decisions early on. So these are the casualties that we received. And just to read them through briefly, we had an open book pelvic fracture, an open compound femur fracture, depressed skull fracture, vertebral compression fracture, and a shear pelvic fracture. And so what you see here are some of the vital signs associated with them. And the question I have for you is I have two surgical teams that will be arriving shortly. Which two of these casualties do you send back into the OR? And so if you want to, feel free to engage in the chat. It'd be really cool if you started kind of putting down, I'd send one, I'd send two, I'd send three, and we'll just go from there. So we'll give you a chance, and I'll shut up so you have a chance to input.
We have a lot of 1s and 3s.
Yeah, looks like it. Give a couple people more a chance to respond. See if anybody's going to be a contrarian and choose 2, 4, or 5. Okay, there you go. So, honestly, the answer to this scenario is going to depend on just how much information that you have. This is the initial information that was given to us. When the casualties actually arrived, my hospital was fully well staffed. We actually had 2 Canadian teams that weren't organic to the hospital come from other parts of the base to support us. So these were the Canadian physicians that would normally go out with the troops. They could be with them fairly close by in case they were injured in the field. We had another American medevac team that came over to help us out as well because they realized that the casualties were already here and their expertise was needed with us. And then we also had an Australian team that came and joined us, and they had an emergency physician and emergency PA that were with them. So they were by far our most well-trained traumatologist at the moment. And so with that, the information that we got is as you see here, and then it didn't change. So what we heard was what we got. And so like you, we took 1 and 3. 5 is a great thought also, and because 5 was just a little bit more stable than 1 and 3 were at the moment, we were able to wait on 5 just a little bit longer. But don't worry, when 5 arrived to us, we immediately had a team, a non-surgical team, working to stabilize 5 until the surgical team could take them back. Because 5 turned out to be the third person that went back, followed by 2 and 4 as well. And so with that, again, a little bit hard to be interactive on Zoom, but I'd love to hear your reasoning for why 1 and 3 need to go back to the OR first. So unpack whatever it is that you know medically about these conditions, and let's talk it through for a little bit. And if you do volunteer, if you ever see me at an appropriate time when I'm not in uniform, I will buy the first round of beers for us to enjoy, celebrating your awesome answer for this question.
I would be happy to get the ball rolling and give people a little more time to think. And we got some answers in here that I can read out too. Nicole from University of Washington said the unstable, low blood pressure and possible hemorrhage. And then James said for 1, it's hemodynamically unstable with a potential to bleed out. And my thoughts for 3 was our GCS was pretty depressed.
Yeah, so these are great reasons, everybody. And with that, how about we talk about 1 first, since that's where a couple of you were going. So open book pelvic fracture. For those of you not familiar with the pathophysiology, you have 7 bones that comprise your pelvis, right? So you have the sacrum, and then you have the 3 paired sets of bones, the ilium, which forms your hip, you have the ischium, which is the portion that we sit on, and then you have the pubic rami, which connected all together in the front. And with an open book pelvic fracture, what happens essentially is that pubic symphysis, which is that soft tissue that holds together the pubic rami, is disrupted somehow. And your gluteal muscles are always kind of pulling back on your pelvis. So as that symphysis pubis is ruptured, the pelvis tends to open up. And that's really, really bad. If you think about it for just a moment, how many liters of blood do you have in your body? Feel free to unmute, or if you want to type, that's fine too. Yeah, that's great. 4 to 6 liters is a perfect answer. So I usually say 5 just for purposes of illustration, but 4 to 6 is great. So 5 liters of blood. Your heart's stroke volume on average is about 70 milliliters per beat. And that's not if you're exercising and exerting yourself. Your heart rate is somewhere between 60 to 100, let's say 70 for ease of illustration. So at rest, 70 times 70, you're circulating your entire blood volume about every minute. But as you can imagine, if you're hurt, excited, you've got your sympathetic charge going on, you're exerting yourself, you go through it a lot more quickly. And so with a pelvic fracture, oftentimes in addition to the damage to the bony soft tissue structures, you can also injure the vascular structures underneath. So you're injured, your heart rate's high, and you're cycling through your blood volume, but every time the blood volume passes through the pelvis, more gets lost. You can lose a lot of blood into your pelvis. And if you think about a Coke bottle as like 2 liters, the kind that you buy in the store, you can easily imagine if you look at your own belly and imagine that your pelvis opened up, that you could drop more than 1 2 liter bottle into your pelvis. So this person, you're exactly right, is at risk of bleeding out. So in any situation, when you see bleeding, what's your first response to stop bleeding? Let's give you an easy example. What do you do if you see someone bleeding from extremity and maybe it's like a gash on their forearm? How do you take care of that? No trick questions here. We're not going to make anybody look stupid on Zoom because we're recording it for posterity. Yeah, right. You apply pressure. Those are great answers. And then if you have a more vigorous bleed and applying pressure is not working, what might you think about next? Yeah, tourniquet. It's a military talk, so you know that we're going to eventually get to the tourniquet. You could try going for proximal pressure on the artery, like the artery bed. That could potentially work. But yeah, in the military, we try and keep it real simple. We throw on a tourniquet and then let the surgeons figure it out later on. So the pelvis is kind of a hard structure to tourniquet, but some of you actually have maybe done an ER rotation, or maybe you were scribing in the ER, or maybe you're doing rotations now on surgery and stuff. What do we have to help us kind of tourniquet the pelvis to stop bleeding, to cause it to tamponade? Oh, I already see the answer there. Yeah, pelvic binder. Yeah, or iliac artery tourniquet. In addition to that, we also have like the mask trousers and stuff like that also. So pelvic binder, basically what it does is it's a device that you put behind the pelvis. It has a whole bunch of strings and stuff like that, such that when you pull it real tight, it just brings the pelvis back together. In Afghanistan, we didn't have a pelvic binder. We didn't think to bring one with us, but we did have a bed sheet, and we had really beefy people. And so thank you, Nicole, for putting up the bed sheet. Appreciate that. So we basically put the bed sheet underneath the individual with which we were working. And then we got those big beefy people to take the bed sheet and to pull it as tightly together as we possibly could. So hopefully at that point we've stopped the bleeding. But of course, what does this individual need with blood pressure of 70/30 and a whole bunch of their boxcars spilled into their pelvis? Yeah, they need two things really. They need blood products, transfusion, fluids potentially, and they also need surgery, right? Because they need definitive stopping of the additional bleeding. And so, good, oxygen, I appreciate that also. So as you know, you have three components of the blood, right? So the red blood cells are really great for carrying oxygen from one point to another. We know that nowadays, and this wasn't the way they practiced, say, maybe 20 years ago, that when someone's going to require a massive transfusion, and it's defined differently by different people, but the thought is that if they're going to require 10 units or more blood products, you're running into the area where you're in a massive transfusion scenario. That in addition to giving red blood cells to move the oxygen from point A to point B, you need to also provide those things that are going to help the bleeding to stop. And so platelets, because you need the bricks that are going to cause the clots to prevent the bleeding to stop, as well as plasma, which has all those factors in it that actually activate the platelets and create the cross lattice that helps them to bind into those clots as well. And so in the military, we did this early on, and of course, civilian trauma centers do this as well. And for those of you who are at Miami, this is what they do at Jackson Memorial as well. 1 to 1 to 1. So one red blood cell, 1 unit packed red blood cells, 1 unit of fresh frozen plasma, 1 unit of platelets. Well, at least at the time in Afghanistan, it's a little different now. Packed red blood cells have a shelf life of roughly about 28 days, I think. Plasma can live almost forever, depending on how you store it. But platelets at that time only lasted about 5 to 7 days. I think we found ways to extend their life a little bit longer. So we didn't keep a whole lot of platelets on the shelf. So we ran through, we used a little bit of fluids, not too much, because you try not to dilute what coagulation factors you have remaining. We gave our packed red blood cells, we gave the plasma, we gave the platelets, but then as we we're going through our protocol, we ran out of platelets. So when you run out of blood products and you still need more, where do you go for that? Yeah, whole blood transfusion, exactly right. What you do in the military is you find the least useful person who has the same blood type as the person you're trying to save, and you render them unconscious and you steal blood until you don't need it anymore. We don't actually do that. Can't see your face. Well, no, I saw one face. Someone's laughing there, so I appreciate that. Yeah, so we have a walking blood bank. The nice thing about the military population is they test us for HIV ridiculously often, but they also make sure that we have like our hepatitis B vaccines and others. And so the risk of transmitting a virus transmissible disease in the military is a little bit less than in the general population. And if someone's going to die if we don't do it, we err on the side of, okay, you might catch something, but we're going to give you this to save your life. Well, my surgeons claim to this day that giving somebody fresh whole blood is superior than giving them individual blood components. Because if you think about it, you have to warm up the red blood cells, the plasma, and the platelets. Because they've been stored on a shelf, they've lost some of their activity, whereas, and they're diluted because of the CPD solution, all the rest that you have to use. But fresh whole blood, that's one arm to another. And with the administration of fresh whole blood, we finally got this individual to stop bleeding, which was amazing. 78 units of blood products to make it work out. Did we do direct patient-to-patient transfusions? What we did was we collected from one patient and then gave it to our trauma casualty. So we didn't have a tube hooked up from one arm to the other. We actually collected it in kits and then moved it over to the patient afterwards. So that's how we did it in that case. Skull fracture, recognizing that I want to be sensitive to any questions you might have in our time. Essentially, the big thing to take away from that case is that if you're a pre-medical student, the only physics that you need to know for medical school is that volume and pressure are inversely related. That's it. You can forget all the rest of the physics that you've learned. Nobody cares that you know all the optical formulas. And really, if you can mention like Poisson's law and all that kind of stuff, it makes you look smart at cocktail parties, but nobody cares. And so essentially volume and pressure, if you have a certain mass and a certain volume, as you decrease the volume, the pressure goes up, assuming that the mass is held constant. Your brain is a fixed mass. Your volume, represented by your skull, as it gets depressed, causes the pressure on your brain to go up. Pressure up in your brain going up, bad. Brain has an escape hatch. It's called your foramen magnum. If the brain goes down there, what happens? I want to see somebody type it in. Herniation, yeah, you die, exactly. So what you need to do in this case is you need to relieve that pressure. And for those of you that are actually on your surgery subspecialty rotations and you've had a chance to see it, this is when they would do a decompressive craniotomy. But when you're in Afghanistan and you don't have access to a neurosurgeon, you do basically what you can find in the textbooks, which is a burr hole procedure, where you basically take a Black & Decker and you just try to drill and try not to hit anything too bad to relieve the pressure in the brain. That's what we ended up doing. We had an oral maxillofacial surgeon do it. He was on a phone talking to a neurosurgeon who was taking him through the steps while he was looking at the pictures in the book. This is pre-YouTube, and managed to save that individual's life. So everybody in the scenario actually gets back home and goes on to lead productive lives. Case number 2, a couple of you asked about that one. That guy had that dreaded complication from a femur fracture. Does anybody know what I might be referring to obliquely? This would be for someone who's already in medical school. What can happen when you have a long bone fracture, either when it happens or when you try to set it? Yeah, compartment syndrome, definitely you have to worry about. That's a really good one. And then if I was to use the term embolism, does that strike? Yeah, fat embolism. Very good. Very, very good. You are going to pass your boards with like flying colors, because that's like a, no, you're never going to have to know this again type of question. But a fat embolism, what happens is that you get some kind of little fleck of fat into your bloodstream, and that fat is highly, highly inflammatory. And so it leads to acute respiratory distress syndrome in some people, disseminated intravascular coagulation, acute renal failure. Our guy completely shut down, and he took a lot to resuscitate, including over 70 units of blood products because he was bleeding out all of his orifices. They had to send a special airplane with a special critical care respiratory team to take him back to Germany and back to the United States. He eventually survived, He decided that the military, he was done with the military. He went on to become a PA, and did not join the military again after that experience. So this is just me being real with all of you tonight. So that's deployment medicine. I'll stop there for a moment because my next story talks about humanitarian assistance, but I'm happy to take any questions that you might have about the deployment medicine part. While you're thinking of any questions, I just want to let you know, my deployment was not nearly this exciting every day. Most days we took 1 or 2 traumas. We didn't have mass cows every single day. A lot of time we were taking care of sick call, ambulatory patients, sports medicine type stuff. You know, the typical stuff that you would get with a bunch of healthy active duty folks. My personal days would usually start at about 3:30 in the morning because that's when my kids were up at home. And so I'd wake up ridiculously early, talk to my kids before they went to bed at night, because Afghanistan is 9.5 hours ahead of the Eastern time zone. It's a poor country, so they can't afford a full hour ahead or behind, so they only get that half hour. And that was a good way to keep in touch with them. And then I would go work at the gym, because that's how I got to have this incredibly swole body that you see here on Zoom this evening. And then we would go eat, and then we go do a little medicine, and then we go eat again, sometimes go to the gym again, talk to our families again. So not nearly as exciting as this story every single day. What year was I in Kandahar? I was there from 2007 January to 2008 April. So I was there for the 15-month ugly stick. Nowadays, military deployments for the Army at least are 9 months in length. Navy tends to be about 6, 7 months. Air Force tends to do shorter deployments, but they tend to do them a little bit more frequently than the Army and Air Force do, or Navy do. All right, talk about humanitarian medicine. So this is a new story, so this is the first time I'm doing it. So your feedback is much appreciated. I tell you a little bit about my time over in Ethiopia, and I have a disclaimer. This is actually not military medicine per se, but one of the cool things about the military is there's a law on the books that goes way, way back that says that a military commander, should they wish to, and should the service member request it, can grant you 2 weeks of leave to do humanitarian work. And a lot of people use this back in the days when there was a lot of military involved with like the Boy Scouts and the Girl Scouts, and they still do that type of thing. But I asked my commander if they would sign off on me going over to Ethiopia with my church. They said, well, what are you going to be doing there? I said, well, I'm going to be doing medical missions. They said, well, sure, we'll sign off on that. So cool rule to take advantage of. If you're in the military, you get paid to do good work around the world. So I really love that. So here's Ethiopia, the going clockwise from about the 10 o'clock position. That's us on the airplane. So this is not the reason you should do an international medical trip, but if you do, you get to go to some pretty cool places. So this is us on our airplane. This is the Abu Dhabi International Airport, which is one of the swankiest airports I've ever been in. I can't believe they actually let me walk through there. I'm a bit of a hick from a very small place in Florida, so my eyes were really wide going through there. And international flights are like the only place where you can still get fed and fed a lot. So every 3 hours, they were bringing us meals to eat. I was seriously gorged by the time I actually got over to Ethiopia. And what you're seeing there at the 2 o'clock position are the Indian lentils that I had while I was in the airplane. So not just food, but like good food over there. And then continuing around, swinging around, if you go to the 7 o'clock position, that's us from our hotel in Addis Ababa. But then I was part of a team that was actually going further remote into the countryside of Ethiopia. And so in the bottom right-hand corner, that's the tiny little airport that had like this 1-story little structure with just one room in it that was like the ticket counter and the outhouse where you can go to relieve yourself afterwards. So that's when I knew that I was in the more rural parts of Ethiopia. And for those of you who've been over there before, I was in Jinka at that point. That's the Jinka Regional Airport. So looking around, it took us a little while to get to where we were going. So we got to the airport, then trains, planes, and automobiles. We got on our buses, drove out. As you can see from the second picture from the left, you get really out into the country, which is really, really cool. Saw folks driving cattle and all the rest. And then because I was on a church mission, in addition to doing medical care, we were also sharing the gospel with people as well. So that's us in one of the local villages, talking to some folks about the gospel. And then if you look at the bottom, just to give you some flavor of the area, that's us eating at an Ethiopian-run restaurant. And I was in Washington, D.C. for about 9 years of my military career. And as it turns out, you may not know this, but Washington, D.C. is the second largest Ethiopian city in the world. We actually have more Ethiopians living in Washington, D.C. than anywhere else besides Addis Ababa. And so we were big fans of Ethiopian food. So it was really cool to have it directly from the source. Another digression, and I apologize for having listened to all my like reminiscences now. When you're over in Ethiopia, it is customary for them to serve the guest meat because to serve you vegetables would be an offense. Like you are our honored guest, we want to serve you the best. I'm not vegan nor vegetarian, but I tend to eat that way whenever possible, just because it's healthier. And honestly, I like the flavors a whole bunch. And so I asked our hostess, like, "Hey, would it be possible to get some lentils?" She's like, "What? You do not like my food? Have I offended you somehow?" I was like, "No, no, I just really like to eat lentils. Can I please have some?" So she made some for me, and they were delicious. The next picture there is one of the Ethiopian churches, very charismatic in the way that they worship. And so here I am, a very white guy, my son, a very white guy. And so we're dancing, we're kind of like they're doing the music and we're kind of doing like the, awkward clap back and forth and everything. And meanwhile, they're up and they're dancing around and they're getting slayed by the spirit. It's really, really cool. And then at the very bottom, you see my son trying to make cultural relations with some of the kids to which we're ministering. And he's showing them how to do the Macarena. There is a reason that all the children in that picture are laughing at that poor white guy trying to make something work like that. So that's Ethiopia. So the medical part of it, the way that the healthcare system is set up in Ethiopia is the way it's set up in a lot of developing countries. Oftentimes, the very first encounter with medical care that people have is with a lay worker that's been trained in maternal and child healthcare issues. So for those of you who've been on humanitarian missions before, this will probably resonate with you. And so they have these things called health posts, which serve their communities. And what they're trying to do is they're trying to make sure that women get linked into maternity care because child morbidity, maternal morbidity are two of the leading causes of death. And in addition to infectious disease and all the rest in Ethiopia. So they're trying to take care of people there. And then they feed into health centers, and those health centers feed into primary hospitals. That's the first layer of care in Ethiopia. And then after that, you have your general hospitals, and then you have your tertiary care hospitals, a lot of which is centered around Addis Ababa as the capital and the most resource. So this is Jinka's regional hospital. This is a primary hospital. And so the first two pictures from the top left are the hospital as you enter it from the front. And then you can see the second one is the hospital from behind. So just a long slung row of different buildings. That's the pharmacy off in the top right corner. In the bottom right corner is the lab. And one of the nice things is that there's a lot of international partners that are interested in the health of the Ethiopians, including the Gates Foundation, among others. And so there's been donations of medical equipment, medical supplies. But one of the difficulties that they run into is that oftentimes they're given the supplies, but then getting the reagents and all the disposable supplies needed to utilize their machines is difficult. And so that's one of the ways that international partners can help them build their health capacity so they can continue to take care of their population. And then the bottom left-hand corner is a picture of one of their wards. Windows were open, so as you can imagine, flies coming in, coming out. And just like in a lot of other countries, it's going to be the family that renders the nursing level type care as opposed to the way that we do it here in the United States. The reason I was brought over to Jinka was not necessarily to provide medical care there on the ground, but they asked for me to assess some of the needs that the hospital had and ways that we and other organizations can partner with them to help build their own capacity. After our time in Jinka, we had the opportunity to get engaged in direct medical care in Addis Ababa. So in the top left corner, that's our team getting out of our van so we can work at one of those more robust health centers in the capital. So this is not a hospital per se. This is a health center where they do more ambulatory care. What you're seeing in the middle top is our Ethiopian physician, PA, nurse practitioner team with which we're working today. Give you a couple of pictures of the buildings, give you an idea of the setup. So this health center is far bigger than what you saw at the regional hospital in Jinka. In the middle bottom picture, that's our pharmacy. So lots of people were sending over there. And then there's me with one of my Ethiopian doctor friends that was working with us. And so the way that they had it set up, we were actually working side by side so that if we saw cases that needed follow-up, we could refer them directly to our Ethiopian colleagues. So it wasn't one of those things where we just drop in, do some good, disrupt the local health system, and then pop back out. We wanted to make sure that people were connected to their own healthcare system and that there are needs that were identified so that people could follow up on them. And then the bottom right is to remind me that we have a case to go through. So let me pull that up a little bit bigger so you can see it. And so most of what we saw over the clinic were people that presented with, say, abdominal pain, children with abdominal pain. So helminth infections are pretty common over there in Ethiopia. So everybody that visited with us got a dose of methimazole to take home with them. acute issues, acute infectious disease. We took care of a whole bunches of stuff like that. But then we occasionally had an interesting case as well. Not that everybody's not interesting, but some stick in your memory. And this was a case that I saw with that doctor that you saw next to me. So let me give you the case, and I'd love for us to generate a differential diagnosis because it's pretty broad for something like this. So this is a 38-year-old with general pains. She has pain in her neck, back, and lower extremities. She finds that she's unable to mount into a taxi without some assistance and has a difficult time getting her hands up to her head. It's been going on for several years, was the best I could characterize it, has left her unable to work. Never been seen by a physician previously. Even though Ethiopian care is free for some categories like maternity care, child care, HIV care, there is still a system of insurance that you need to pay into in Ethiopia. And there's also limited assets when you get to the more rural areas. Her heart rate, 64, looks okay. Blood pressure is a little bit high. She has visible muscle wasting to look at her. So she doesn't look just cachectic, because she does look like she's cachectic also. But you can see like around the temporalis and the exposed muscles that there's some wasting associated with them. She has no heart murmurs on the exam, no arrhythmias noted, but she does have diminished strength. Her bilateral upper extremities are weaker than her distal, bilateral upper extremities are weaker than her bilateral lower extremities, and her distal upper extremities are weaker than the proximal ones. So with that, you can't be wrong with this differential diagnosis because unfortunately I didn't get the rest of the story. She was referred eventually to a neurologist and to a more advanced diagnostic testing center, and I had to leave the country before the results came back. But I'll ask you, let's throw up a differential diagnosis. This will help you on the wards. Yeah, cancer is a broad category. Absolutely. You think muscle wasting, cachexia, good. Oh, okay. Spinal cord compression, very interesting one. You're picking up on the muscle weakness there. Good. And maybe she doesn't have good access to nutritious calories. Absolutely. Lambert-Eaton, really, really cool one. Okay, so myasthenia gravis, Lambert-Eaton, um, one of those disorders such that you get this gradual extinction of your muscle responses, like that. What else do you guys have? If you're big house fans, you would say lupus at this point because it's never lupus, but it's always in the differential, right? Also thyroid. Thyroid's always in the differential. Back in my day when I was in medical school, it was always syphilis was always in the differential. Yeah, there's a lot of things you could think about here. So with the approach to generalized muscle weakness, rhabdo, yeah, good one, good thought. The muscles could be breaking down for some reason. You're thinking about lupus. I appreciate that. Thank you. So this is kind of one of those ones where you can pull out your vitamins mnemonic or one of your other mnemonics that takes you through the different systems to think about. This could certainly be one of those cases of an endocrine dysfunction. So think about things like Addison's disease or adrenal hypoactivity, right? So maybe they just don't produce the mineralocorticoids or the glucocorticoids that they need to keep the weight up. So that's a possibility. It can also be associated with muscle weakness. Think about thyroid diseases, hypothyroidism. Those are certainly on your differential diagnosis as well. Think about your storage diseases. So this could be a lipid storage disease. It could be a glycogen storage disease. Those are oftentimes associated with muscle problems. It could be a primary muscle dystrophy or one of the related conditions associated with that. Cancer is absolutely in the differential diagnosis. Multiple sclerosis should be in your differential diagnosis as well. Various infections could possibly cause this, vasculitides. It's a really, really, really broad differential. So this is one of those cases where you wouldn't be wrong with whatever you said because really it's so undifferentiated. If you were trying to evaluate her, there's a bunch of things that you could order. Personally, I'd start with chemistry panel. I'd start with some hormone assays like a TSH to at least get it started. You might think that if she was here in the United States, she'd be referred fairly quickly for maybe a muscle biopsy or an EMG, nerve conduction study. You might think that if you're worried about, depending on where you're worried, you might do some imaging studies as well. A lot of different ways this could go. So that's good. Good thoughts, everybody. Appreciate that. From the medical missions that I've been on, so this was not the only, I've done several other medical missions as well. For those of you that are engaged in humanitarian medicine at some point in your career, these are the couple pearls that I took away from it. The first is not to do harm. You certainly don't want to harm a patient, but you also don't want to harm the health infrastructure. I went on a very unsatisfying medical mission to Ecuador at one point where we went in, we did some medicine, and then we popped back out again. And at this, what we were doing at the same time was making it hard for the pharmacy that actually needed to stay in business to be able to market its medications when we just gave a bunch away for free. And so putting a pharmacist out of business, that doesn't leave people better off. Putting primary care providers or specialty providers out of business because you've done the surgeries that they otherwise would have helped them to stay in business, or to do the diagnostic studies that would have helped them stay in business, that doesn't help them out. And you don't want to harm by undermining public confidence in one's own medical institutions. Frequently in Afghanistan, we would have people that would come by wanting the Western medicine and not trusting their own healthcare providers who had also been trained to provide within their country. Second principle, partner with knowledgeable people. There are people in the country that know the system far better than you, know what the capabilities are, and also know what the local patterns of diseases are as well. As best you can, try to enhance people's respect for their own institutions. We already talked about that. Make yourself knowledgeable before you go over anywhere. You should know about the endemic diseases. So if you're interested in humanitarian medicine, you have an opportunity to take a tropical medicine course, then do it. That's a great thing to do. And also understand how the health system works so you can plug in with it appropriately. And of course, open yourself up to a whole bunch of learning. So that's story number 2. I'll pause for a moment in case there's questions, and then I'll make the last story just a little bit quicker so that we can have a general Q&A time afterwards in case you have things you want to know about. All right, I have ADHD, so I can't stop for too long. Here we go. Moving on. So story number 3, this is the one that's ongoing. This is the one that's about medical school. So this will resonate. This is where you're at right now. One of the things we do a little bit different in the military is that we recognize that our graduates are going to be put in situations like Afghanistan or like Ethiopia, and they need to have a versatile skill set that will help them each way. That's not to say that military medicine is superior to what you're doing. Each one of the medical schools that you attend or that you hope to attend have something unique that they're giving to you that no other medical school can do. So for instance, I know a bunch of you are at Miami. There is no ER in the world or trauma center in the world that compares with what you see at Jackson Memorial. Oh my gosh, the trauma, the polytrauma that you take care of there, you're just not going to get that exposure anywhere else. So kudos to you for choosing a school that gives that to you. But the same could be said of all the other medical schools like Creighton or UCSF or Washington or wherever you find yourself. Well, at the Uniformed Services University, one of the things that we try to give our students, in addition to leadership capabilities, is versatility, the ability to respond to whatever is thrown at you. So what you're seeing right here is one of our field training exercises where our students are put into the role of acting as a field surgeon and taking care of a patient at the point of injury, point of care. And what the patient wearing the sports bra is one of our first year students who's role playing the scenario for that surgeon. You might think, okay, well, that looks a little bit on the fake side. And yeah, it does. But when we as a faculty ratchet up the stress on you, you get really into it really quickly. We try to teach them some pretty cool things. So in addition to basic patient care, we also have to teach them about medevac, loading patients onto helicopters, onto ambulances, how to use those assets to get people to the care that they need as quickly as humanly possible. And then we're trying to ratchet up the stress. So you're good at taking care of one patient? Great. Now we're going to have you take care of 2 patients. Oh, you did that pretty well? Great. Now we're going to have you take care of patients while your convoy is being attacked and you're under fire at the same time. And we just kind of build and build and build to the point where we get to the mass casualties. So this is the last interactive exercise that I have for you. You are now the lead triage officer. So in the military's case, oftentimes you'll be a dentist or advanced practice practitioner. Sorry, I know there's a better term for that. I'm blanking on it right off the top of my head, but a PA or a nurse practitioner. And so your physician's going to be doing individual care, your surgeons are going to be doing their care, but you're responsible for creating order out of the chaos. And this is something that we force our students to work through with live patients and also simulated patients as well. So let me give you the scenario. Oh no, the local village was attacked. You have multiple casualties. What I need to know from you is what's your system for triaging these people. Triage is simply recognizing that you have more need than you have assets. And so you have to prioritize the way in which you're going to take care of people. So feel free to look through these And then from a general principle standpoint, give me a couple rules that you're going to follow to appropriately triage who gets treated first, who gets treated second. Which categories of people would you want to treat first? Which categories would you want to treat second? So think about that. I'll stop talking so you can hear yourself. All right, so from Megan, we have manage your airways and breathing first. Nicole, also prioritizing your airway. I like the way that you're thinking. The way we treat people in the CAB. Okay, so I have somebody there that has a little trauma training also. Good. Obviously, these are all correct answers. The way we go about it in the military is that just like you do, we're always thinking about ABCs. And James, you're absolutely right. Airway people tend to decompensate before breathing people tend to decompensate before circulatory people. And absolutely, we color code people because we want to make it easy for ourselves. So oftentimes we use big bright tape to give us an idea, is this an airway person, is this a breathing person, so that our physicians can go around picking up on who needs care next. We also recognize, at least on the battlefield, that the #1 preventable cause of death is massive exsanguination. So what we'll do is we'll do a very cursory sweep for anybody that has a C circulatory bleeding issue. We'll try to stabilize it best as we can, often with a tourniquet, and then we'll go to our airways and our breathing and our circulation, just like you would do with ATLS, just like you would do with ACLS and BLS as well. And so with these patients here, which ones are the ones you're worried about their airway? So, or actually, no, let's do it military. Which are the ones that you put a tourniquet on them and then you can ignore them for a little bit? So 2, absolutely. 2 sounds really horrible, but throw a tourniquet on them. Okay, 9, good, good. Yeah, 2 and 9. Throw a tourniquet on them and let's move on to the other people. Okay, so now that that's taken care of, who are our airway people? The ones that are like, oh, hey, we might need to intubate, trach, or do something else to preserve an airway. Okay, see 1, 6, 8. Good, good. Yeah, 3 also. So let's talk about those just for a little bit. So with 3, we don't know what her airway status is because she's not breathing. It could be that she has a simple obstruction. If we relieve the obstruction, we can get her breathing again. So she's definitely worth a quick check. She might fall into our A category, but if we get to her and she's expired, then we're going to move on to somebody else, obviously. Okay, so that's number 3. And then #1, we're definitely going to get to. I'm going to put them into the breathing category because I think that their trauma is less up here and more down here. So we have just a little bit more time to get to them, but definitely they are high on our priority as well. Let's see, 5, yeah, burn marks to the face. We have to worry about a heat inhalation injury. And when you get heat injury to your mucosal membranes, they tend to swell. This is someone who's on the verge of losing their airway. So we might want to go ahead and prophylactically intubate just so we don't have to do it under duress. And then I think you said 8 as well. Yeah, red froth of the mouth, that could be an upper airway issue. It could be a breathing issue. One or the other. We'll have to sort it out. And then 5, yeah, okay, we talked about that. Good. Okay. And then 6, yeah, a child that's struggling to breathe. We're not sure what the mechanism of injury is. That certainly sounds airway. And then what are our B category, our breathing ones? So I mentioned that 1 could be someone that maybe is needing a needle decompression or possibly a chest tube with a penetrating thoracic injury. They may have a pneumothorax or a hemothorax. Does anybody else fall into the B category? And maybe the one with the frothy breathing, right? Yeah, good. Okay. And then who's our C category? So we put some tourniquets on a couple of them. So you get those for free. So you get 2 and you get 9. Those are your C category, your circulatory issues. And there's one more that I snuck in there. Yeah, 7. So a swollen, bruised abdomen, that is internal abdominal bleeding until proven otherwise. That person needs a surgeon. So it sounds like we're not too concerned about #4, the screaming baby. I know, right? There's always a distractor that's in there. So it could be something, but you're going to give it a quick once over and then you're going to move on to your other patients. So that's one of the things that we also teach our students in the military. At the Uniformed Services University, we do it as part of their curriculum. For those that take the Health Profession Scholarship, we actually have a special course called the Combat Casualty Care course, where we take you through the ATLS curriculum, we get you certified in ATLS, and then we put you through something very, very similar so you have the opportunity to learn how to do this as well. So great job, everybody. Yeah, and then at the end of the day, you wipe your brow and you're like, well, glad that's over. So that's it. These are the stories that we shared during this time. We talked about a combat zone deployment. We talked about what a humanitarian mission could look like, and our military humanitarian missions can look very similar, especially when we send our big hospital ships out to partner with countries that border the Pacific or the Atlantic Ocean. And then we talked about the training that could potentially help you succeed in these different environments. So with that, I'll stop, and then I'll open it up for any general questions that you have. I think I left 10 minutes, and then I'll give you my email in case there's questions that you maybe don't feel comfortable asking in this forum, with which you'd like to follow with me. And then if you're just like, oh my gosh, sign me up now, I need to talk to a recruiter, I have those web addresses for you as well. So there they are. I put Army first, just because I do. And then there's the Navy and there's the Air Force also. And then there's my personal email address if you want to get in touch with me. But yeah, any questions, feel free to ask.
Thank you so much. This was amazing, and I loved how interactive it was. I'll definitely start us off with a question. I know you addressed a lot of them throughout it. Is there anything in particular you keep in mind on humanitarian missions to support the local healthcare infrastructure?
Yeah, so one of the really nice things that I liked about our trip to Ethiopia is that a lot of stuff happened on the front end. And so a couple members of our church had very, very strong ties to Ethiopia. They're Ethiopian by birth. They have lots of family that are over there. So they proactively reached out to the Ethiopian government, and they found places that were in need of extra medical support to take care of a backlog of patients that their physicians weren't able to see. And so because of all that preparatory work up ahead of time, when we went over there, we weren't doing just feel good medicine to make ourselves feel good. We were actually helping their own capacity get a throughput of patients. And as you know, most patients only need primary care, but there are some that need to move on to subspecialty care. And so if we could get through all those primary care cases, that meant that we could feed into their system the cases that needed more dedicated specialty care that they could take care of. And so I thought that was a good way to work it, where we were basically enhancing their own system as opposed to trying to force our own on them. So I don't know if that answers all of your questions, but that's at least one thing that really was in my mind. All right. So, oh my gosh, there's a lot of questions. This is great. Okay. When are you able to join the Army as a doctor? Multiple different places. You can actually take a scholarship for medical school, and it doesn't have to be before you start medical school. They also have 2- and 3-year scholarships that are available. And then you can also take, there's actually a stipend that they can give you as a resident if you want to be a reserve doctor. So that means a doctor that works part-time for the military. And then you can come in as a fully trained physician after residency. And that's usually when they throw a lot of money at you. So I think there's like $256,000 that they give you to help pay back your loans. And of course, you get your doctor's salary and all the rest. So you can come in at any point that makes the most sense to you. All right, as far as composure, the great thing about medicine is that we've become increasingly versatile with algorithms. And one thing about ATLS is that for those of you who've taken the ATLS course, they drill into you that every trauma patient you ever assess is always the same way. Scene safety. In the military, we think scene safety, return fire, take them out of the active engagement zone. And then it's quick sweep for blood, and then it's A, B, C. And we teach people to triage in the same way as well. So when you drill so much that something that normally takes a lot of cognitive processing becomes muscle memory, that's when you get that wonderful experience of flow, when everything around you slows down because you're just so versed in it that you're in that place where you're in the flow, which is really, really nice. All right, so capital events. Main options for upper level medical students. So I think we addressed that question. You can enter in as a resident or as a full-fledged physician. Dermatologic issues. Oh, that's a really interesting question. We dealt with derm a lot. The nice thing is that when you're in a deployed environment, you simply need to recognize when you have a dermatologic issue that indicates underlying disease that needs to be treated, or a dermatologic issue that if it doesn't get treatment sooner rather than later, could be a problem for somebody, and that person needs to be evacuated. So that's kind of how we dealt with that. And of course, we ran into the typical tinea, fungal infections, and the other things that you would expect, and eczema and all the rest. Sign up for the combat casualty course. Well, if you're in the military, you're going to get that as an intern. So as an intern, they're going to send you here to San Antonio, and you're going to have an opportunity to practice running around the field, which is actually a lot more fun than it sounds. And then if you are interested in doing it in a non-military way, as you know, they have the wilderness medicine course, which is pretty cool. So you get an opportunity to go and practice some of this austere medicine and an environment like that. And I must admit, you probably know more about the opportunities for those who are not in the military than I do. So I'll point you to your leadership. And then finally, options for someone who has injuries but wants to do military medicine. Well, good news is that in our hospitals, we actually have a balance of civilian health providers as well as military providers. And so if you're interested in practicing military medicine, you can certainly work as a civilian at one of our hospitals, including our hospitals that are overseas as well. So if you want to take care of our soldiers, sailors, airmen, and Marines that way, you can do that. And then also they have some times where they'll deploy civilians, always voluntary when you're a civilian, and you can potentially get a little bit closer to where the action is if you're interested in doing that. Oh, I have not taken the austere medicine course at Madigan. Yeah, so no, I've not done that before. Probably the closest I got to true wilderness medicine, besides my deployment experiences, is at one time when I was teaching at Bushmaster, our student experience in austere medicine. I was actually in the same team as Paul Auerbach, who I'm sure is a huge name for all of you out there. He's the guy that actually wrote the wilderness medicine textbook, and super nice guy from California. Resource for exploring the differences of culture from different branches. Oh, okay. So Army, Navy, and Air Force, what I can tell you just right off the bat is that 85% of what we do is exactly the same, and the medicine is exactly alike. Army, land-based, Navy, sea-based, Air Force, air-based. And so the cultures build up around those distinctions, probably more than we have time to go into on this. And honestly, I've had students go into all three branches, and they're completely happy with their choices. Whew, all right, we should give people an opportunity to sign out so they can get dinner and do all the other things they need to do with their lives. Thanks for having me. I really appreciate it, everybody.
Yes, big thank you again. And if you wouldn't mind staying on for 1 minute, we'd love just to say thank you again.
Okay.
Thanks for coming, everybody.
Well, thank you all for doing this. I know it takes a lot to have your normal medical school and undergraduate responsibilities, and at the same time, try to put on this extra